जाते बंद. Okay. So goals of pulmonary rehab. Uh, we saw the goals of pulmonary rehabilitation: improving the quality of life of patient, decrease the burden of healthcare on patient's family and the community, increasing the patient adherence to prescribed therapies. What are specific physiotherapeutic goals that we are going to look into, for which we will be undertaking physiotherapeutic interventions? Will be reducing dyspnea, breathlessness, cough, chest pain, and other relatable symptoms according to the case that you have been allotted, or according to whatever symptoms your patient is having, whatever complaints he is having. Enhance patient's sense of control over their own condition. He should know what is the condition he is suffering from, why is it happening. So it doesn't mean that you go into entire pathophysiology, explain entire pathophysiology of the patient. He is not going to understand. You should just use your layman terms to make him understand what is he suffering from, why is it happening, and how he can control on his own. Okay. Improve the patient's functional exercise capacity. This will help improve his endurance. This will help improve his day-to-day activities. Okay, because we all know that a dyspneic patient, we take the questionnaires, we mark according to the whatever the questionnaire says. We know how a dyspneic patient can how dyspnea or breathlessness can enable the patient to not move from one place. Like patient will be sitting and even they'll be getting breathless, so they cannot just move around. It'll be very tiresome for them. So you need to enhance patient's functional capacity. Improve the respiratory muscle strength of the patient. We'll see how is it correlated to dyspnea and other symptoms. Improve overall health status of the patient and provide suitable ergonomic advice for the same. Okay. So, what are the components of pulmonary rehabilitation? Whatever team members we all saw will together make sure that all these components of pulmonary rehabilitation are taken care by one or the other member. Okay. Patient education will be done by everyone. Dyspnea management. Dyspnea management is a major component, although this is basically the symptom management. So it can be cough management, it can be chest tightness management, it can be dyspnea management, whatever according to the patient's requirement. Respiratory muscle training, majorly done by us physiotherapists. Pharmacological therapy will be taken care by the chest physician, intensivist, etc. Psychological intervention. We'll see why do we need psychological intervention during these conditions. Then nutritional management. What patient should eat, what patient should not eat, how they should maintain their diet, all will be taken care by the dietitian. And exercise training, where we step in. Okay. So all these components should be included during the rehabilitation of the patient with chronic lung disease. We'll see one by one. Dyspnea. Most of the respiratory diseases, you can see here the flow chart, most of the respiratory diseases will lead to dyspnea. Dyspnea, because of the patient is taking very shallow, very small breaths, the patient does not have appropriate oxygen transfusion. There is mismatch in V by Q ratio. The required oxygen is not reaching the periphery. The muscles become weak because of which, and it lead to inactivity of the patient. If you see in breathless patient, they are not able to change their clothes properly. They get breathless even while changing their clothes, like grade 5 dyspneic patients. So it leads to inactivity. Because it has led to inactivity of the patient, we all know what are the side effects of bedridden diseases. It will always lead to deconditioning of the muscles, deconditioning, wasting of the muscles. So it obviously our the muscles which help in respirations are also skeletal muscles, and thus they will also undergo deconditioning. So there is deconditioning not only of peripheral but also of respiratory muscles, which will further lead to increased work of breathing, thus increased dyspnea and increase in the symptoms, because your expiratory and your inspiratory muscles are not working. You cannot cough well, you cannot inspire well, which will lead to further inactivity and ultimately death. So if we manage dyspnea at this very first level, we can improve the quality of life of patient and help majorly in their rehabilitation and treatment. What are the causes of dyspnea? Why does this dyspnea happen? It is basically due to increased central respiratory drive, that is V by Q mismatch leads to increased central respiratory drive and thus increased ventilatory demand, thus hyperventilation, shallow ventilation and breathlessness dyspnea. All this goes hand in hand. It is a cycle, keep in mind. We saw because of this it will lead to weakness of respiratory muscles, and how weakness of respiratory muscles will again lead to more dyspnea. The inspiratory muscles are weak, they cannot inspire properly, they cannot cough out whatever mucus is being produced, because of which there is accumulation of mucus. Accumulation of mucus will lead to narrowing of the airways. Narrowing of the airways will further lead to increased respiratory impedance. You can see here increased respiratory impedance or inspiratory resistance, because of which there will be further V by Q mismatch and so on. The vicious cycle goes on. So we know that why is it necessary to reduce dyspnea, to manage breathlessness, to educate patient in first place, that if you do not do the respiratory exercises, if you do not perform breathing exercises religiously, then what it may lead to, what problems the patient will cause. It is your duty to educate the patient. Okay, so how do you measure dyspnea? There are direct measures and there are indirect measures. Direct measures, as we all know, there is MMRC and ATS, which is majorly used for respiratory dyspnea, and NYHA, which is usually used for cardiac dyspnea or cardiac breathlessness. So you can use these scales to measure the level of breathlessness. To help, it helps you you diagnostically as well as prognostically. After your therapy, you can check it again, that how you can see your prognosis. Then you can see if the grade has reduced or increased, or even during your therapy session, you can check the prognosis. Indirect measures are baseline dyspnea index, transitional dyspnea index, and chronic respiratory questionnaire. All these will help you to grade objectively the level of dyspnea and also help you to determine the prognosis. So how do we manage dyspnea? Okay, here the thing is that I have taken individual causes of dyspnea and explained that how will you manage by altering that cause, by altering the cause at the central level and peripheral level, that is inside the respiratory system. But mostly these things are taken care by your pharmacotherapy, which should always be followed with your physiotherapy exercises, the breathing exercise, inspiratory exercise, expiratory exercise, your positional drainage, the PDs, etc. We'll see how we use it. All these will depend on the type of affection your patient has and your judgment that what you want your patient to achieve. Okay, so what we can do is we can reduce the ventilatory demand of the patient by either reducing the metabolic load, peripheral metabolic load of the patient, or reducing the central drive of the patient. How you can reduce the central drive of the patient? We all know you have central pneumatic centers, you have peripheral pneumatic centers. So